And thank you for the opportunity to present today. As Aaron mentioned, I am Dr. Carissa Marie Baker-Smith. I'm a pediatric cardiologist, a preventive cardiologist at Nemours, and I was also recently awarded one of the Embry pilot grants for 2 years. And the title of my grant is Neighborhood Deprivation Index Predicts Loss of Ideal Cardiovascular Health in Adolescents. So just some background. The American Heart Association defines ideal cardiovascular health status as the presence of 4 health behaviors and 3 health factors. And we know that ideal cardiovascular health in adults is associated with lower rates of premature cardiovascular disease. It's estimated that as much as 70% of that risk can be reduced if, as young adults become older adults, they maintain ideal cardiovascular health status. Unfortunately, most adults do not possess ideal cardiovascular health status. Predictors of loss of this ideal cardiovascular health may include environmental factors. We do know in U.S. as well as non-U.S. studies, so international studies, have demonstrated that where one lives, so inclusive of the neighborhood deprivation, or you can describe it in terms of census blocks, so area deprivation, that areas of high deprivation are associated with loss of ideal cardiovascular health in adults. But more recent data, and this is inclusive of even very recent data that was published in the New England Journal just a few weeks ago, we do know that cardiovascular health does begin, and loss of ideal cardiovascular health can begin in childhood and adolescence. And so given that we know this, that cardiovascular disease risk factors begin in youth, we hypothesize that indices of neighborhood deprivation and area deprivation are associated with loss of ideal cardiovascular health during the adolescent period. So aim 1 of the grant is to quantify the relationship between neighborhood deprivation index and cardiovascular health status in youth at 18 years of age. So to carry out this portion of the aim, currently we are analyzing NHANES data as well as the census data from 2008 to 2018. And what we're looking at is quantifying the relationship between the neighborhood deprivation index and cardiovascular health status at 13 and 18 years of age. And what we predict is that the neighborhood deprivation index is a significant predictor of cardiovascular health status at age 18 years, and that neighborhood deprivation index is associated with cardiovascular health status during the early parts of adolescence as well, so as early as 13 years of age, with greater impact on cardiovascular health status during the latter adolescence. And then we will adjust for other potential covariates such as race and ethnicity, which have traditionally been used to describe some of the social factors related to cardiovascular health status to control for some of those relationships in this analysis. So to give you just a little bit more detail, we're going to also aim 2 is to assess the relationship between more of the census area deprivation, so area deprivation index and cardiovascular health status at 18 years of age. And for that, we're using a different data source. We're using the PedsNet Nemours, in particular Delaware electronic medical record data to quantify that relationship between area deprivation and cardiovascular health status. And again, we predict that the area deprivation index is a significant predictor of cardiovascular health status at 18 years of age within the state after adjusting for race and ethnicity. Well, so for aim 1, again, it would make sense that if someone grows up in a very deprived area, that could have an impact on their future and present cardiovascular health. And so in collaboration with one of my team members who's actually works within the NIH and has published in this area within adults, we are creating an NDI using the NHANES restricted data. And then again, we're assessing the relationship between this neighborhood deprivation index and cardiovascular health status. So these are the factors which contribute to how we define ideal cardiovascular health here, and this is as defined by the American Heart Association. So what you'll see is that across the top rows are the behaviors such as smoking status, body mass index, physical activity level, and the healthy diet score. And then across the bottom 3 rows, what you'll see is that we assess the health factors, which is total cholesterol, blood pressure, and fasting blood glucose levels. And we'll be using hemoglobin A1C as a replacement for the fasting glucose. And then we'll adjust for the relevant covariates, potential mediators, and moderators. So I just wanted to pause because sometimes people wonder, well, what is a mediator? What's a confounder? What's a moderator? What's a covariate? And so we use a unique statistical approach in this project, and it is looking at not just associations, but causal relationships. So exposure leads to an outcome. A confounder is a variable that may be related to both the intervention or the exposure and the outcome. A mediator is in the path of the exposure to the outcome. A moderator may affect the effect size or the direction of the relationship between the exposure and the outcome. And the covariate can explain part of the relationship and the variability in the outcome associated with that potential exposure. So again, our exposure of interest is the deprivation of the area in which a child grows, and our outcome of interest is cardiovascular health status as defined by those AHA health factors and health behaviors. In the meantime, we're also looking at household socioeconomic factors as potential confounder and assessing the impact of those household socioeconomic factors on ideal cardiovascular health status. So just as I come to a conclusion, I just want to show you some of our preliminary data. I did obtain, as Aaron had described to you, there are Delaware vouchers. They were called Embry Medicaid Pilot Awards initially. So I was awarded one of those a year ago, and we used Delaware Medicaid data and inclusion of the area deprivation index to assess the relationship between area deprivation and high blood pressure, hypertension diagnosis in kids, looking at causal relationships as mediated by obesity and controlling for those factors that we could control for. So this work is currently under review in a journal, Journal of American College of Cardiology. And what we are demonstrating here is that as the degree of area deprivation increases to the highest degree of deprivation, you can see there's sort of this trend up in the prevalence of elevated blood pressure and hypertension. This uptick here at the lowest deprivation is unclear why. It just may be more elevated blood pressure. We did not see that uptick when we looked just at hypertension diagnosis alone. So again, this would support some of our hypotheses that area deprivation does in fact contribute to the prevalence presence of high blood pressure, which is one of the ideal health factor or one of the health factors in that total cardiovascular health score. And then again, this is just some work that is under review, but looking at the relationship in a causal way between area deprivation and the impact on elevated blood pressure and hypertension diagnosis. In our work, we found that about 13% increased odds of hypertension diagnosis associated with area deprivation greater than or equal to 50, which was partially mediated by the presence of obesity. So doing the math, what that suggests is when you look at the factors, there's a potential 81% reduction in hypertension diagnosis by controlling for obesity amongst kids with area deprivation index above 50. So I thank you for your time, and I'll take any questions at this time.